his neck. So it's been there for 2 years and it's painless. He has no history of smoking or heavy alcohol intake. And if we look into his pharynx, this tonsil here is atrophic, which I would expect in a 60-year-old, but this tonsillar abscesses don't hang around for 2 years and they're very painful. Burkitt's lymphoma, I don't think so. This is not the mandible and this is not a bony tumor, so we can forget about option 4. And benign tonsillar hypertrophy would involve both tonsils, not just one. And the general rule of thumb is always pick the most dangerous diagnosis, and that would be tonsillar cancer. And that's the correct answer here. So this is a difficult tumor to diagnose. We'll look at the differential diagnosis: peritonsillar abscesses, pus, pain, fever, chills, signs of inflammation. If you look in there, it looks like this. A Burkitt's lymphoma, described by Dennis Burkitt. This is how Epstein-Barr virus was discovered in these tumors. Oh shit, what did you guys do?
No, it wasn't showing, so there.
No.
Okay.
So Burkitt's lymphoma is a B-cell lymphoma. It's initiated by Epstein-Barr virus, and in children it looks like this. One injection of cyclophosphamide and this goes away. Incidentally, as an aside, Epstein-Barr virus is also responsible for nasopharyngeal carcinoma in Chinese and African men, and we've discussed that issue in the past. So carcinoma, the tonsil, is actually a squamous cell malignancy. It is associated with human papilloma virus 16, so that we would hope that the issue of vaccinating young women and men might put an end to this tumor. Here's another example: tonsillar carcinoma. This is an osteoma of the mandible. So this is a benign bone tumor and something entirely different than what we saw today. And this would be an example of bilateral tonsillar hypertrophy. This is not an indication for operation, incidentally. And so both tonsils would be involved, and this would be a condition that we would expect in childhood. The topic in the New England Journal for the most part this week has to do with HIV. And you'll recall this is an RNA retrovirus. It's taken up by cells that express CD4 receptor with an adapter protein CCR5. The virus is incorporated intracellularly. Its RNA is then translated to DNA by the enzyme reverse transcriptase. This is incorporated into the genome in these cells, which then makes lots more viruses. And this is how this condition spreads. We know an incredible amount about this organism. And 30 years ago, effective treatments were introduced, antiretroviral therapies, abbreviated as ART. So the 3 papers that I'm going to present to you involve the treatment of HIV, the suppression of HIV in Africa. So we have to look at a little anatomy. So the equator runs through about here. And this is Kenya in East Africa, and Uganda is here. Botswana, which is a locked-in little country above South Africa, is here, and here is South Africa. And so that'll give you an idea of where these places are. The first trial involves the effect of universal testing and treatment on HIV incidence. One would reason that if we had a massive screening program to identify anybody that is HIV positive, and if all those individuals were immediately treated with ART, that we would probably suppress the spread of HIV to non-infected persons in populations. Reasonable hypothesis, but we have to compare that idea to what consists of usual care in Africa. So in this study, there are 3 particular arms. Arm A, massive screening. Anybody that's HIV positive receives ART. Arm B, also massive screening. The people that are positive get ART, but only if their CD4 count is below 400 cells. And Arm C gets usual care, which is incidentally is pretty good. And I think that that explains some of the outcomes in the studies that I'm going to show you. So here are group A, B, and C. Interestingly enough, a lot more women participated, although entire communities were randomized here. This is not an individual randomization, communities were randomized here. And the female participants outnumber the male participants more than 2 to 1. So I'm not quite sure how that came down, unless the males hide out and refuse to participate in these kinds of endeavors, which is possible. One of the issues involves male circumcision, because there's pretty good evidence that circumcised males are less inclined to spread HIV than uncircumcised males, and I have some information about that here in this column. Medical circumcision does not mean that we have a tablet that causes your foreskin to fall off. Medical circumcision means circumcision for medical reasons as opposed to religious reasons, which is the only other reason that I would come to my mind. So here are the people. And some of them in the screening program were already HIV positive, but about 80% in each of these 3 groups was not. So the statistical comparison here involves all 3 groups in each of these these communities were matched in terms of a variety of criteria that you can inspect at your leisure. But we would expect that A would beat B, and B would beat C, and A would beat B and C. But that's not what happened. A was no better than C, and B beat C and also beat A, and nobody knows why. So B again was a group, massive screening, but the people only got ART when their CD4 count was below 400. And this graph in essence shows that. Here's HIV incidence comparing A to C. Things go up and down, no statistical difference. If we look at the ratio residuals, no statistical difference. But if we compare B to C, B beats C. This study, incidentally, was sponsored by NIH, if you were wondering where the money comes from. There's some, here are the people that are HIV positive, and I guess it looks like the compliance to ART is, I would hope that it's 100%, but it's not. And there's some age differences here. Things sort of go up and down. And so the authors tried to explain this result, and they couldn't, or at least they couldn't explain it to me. One possibility that they mentioned I thought was interesting, wide-scale ART delivery in group A may have led to sexual disinhibition. Not quite sure what that is. Or de-emphasis of primary prevention. But the bottom line is that they don't really know, and so the study is, in my view, pretty much a bust. So here's the next study. This involves Uganda and Kenya. This was also funded by NIH. And baseline HIV and multi-disease testing and national guidelines with restricted ART compared to usual care, which is also, I mean, these communities screen for HIV in Africa, and ART is freely available to the people that are willing to swallow it. Now in this study, here's Uganda and here's Kenya. None of the subjects were living in Lake Victoria, as you can see here. So these are the communities that were randomized to aggressive screening and treatment compared to usual care. And what I also like about this particular study is the authors paid attention to some other things. So they measured the person's blood pressure, and if they had hypertension, they focused on treating it, which I think is a good idea. That was all available in the supplement, incidentally, so they're low key on this issue. Then they also looked at whether or not they had type 2 diabetes, and if they did, they at least offered the patients metformin. So that was an aside. Complicated community randomization here, and how many patients were enumerated and how many were lost to follow-up as a function of age, etc. But at any rate, there are almost 100,000 people in both of these groups, in these randomized communities in each of the groups, 99,000 in one and 87,000 in another, so those are a lot of patients. And here are some characteristics in this particular study. Male sex, well, the breakdown here is more in the direction of 50-50 compared to the first study. And their educational levels and occupational levels and this sort of thing are outlined in this complicated table. But what we see here in terms of the HIV difference is looks like they got the subjects in the intervention group to take more ART, but the population level of plasma HIV RNA was not significantly different. So in terms of the HIV outcome, in essence, it was negative. We can look at the breakdown of the various regions here, and there were no significant differences found, although in the patients who were HIV positive, the investigators paid attention to tuberculosis and they intervened, and so a tuberculosis outcome was better in the intervention group than in the control group. So at least that's something. And they managed to lower blood pressure in the intervention group better than in the control group, and the same was the case for diabetes control, so at least some benefit accrued for the patients, although the HIV outcome was basically negative. I think that's an indicator that HIV care in Africa is better than the investigators expected. The third study along these lines is Botswana. And Botswana is a small landlocked country slightly north of South Africa. It has absolutely no natural resources, and the people are not wealthy. And maybe for this reason, it has a democratic form of government instead of an extractive dictatorship. And I was also interested to observe that Botswana, they funded themselves, whereas the first two studies were sponsored by NIH. That was also remarkable. Similar kind of strategy, again, randomization of communities rather than individuals. And so 15 villages in the intervention group compared to 15 villages in the control group, and it had to do with the screening and when ART was started. And we can look at the eligible populations, and looks like the groups were similar in terms of randomization. The participants who reported circumcision doesn't look like it's too popular among these folks. And the investigators also included trying to convince the participants in the treatment group to get circumcised with only a moderate degree of success. But what we see here is that the intervention group did better than the standard care group in terms of AIDS incidence through time. And that difference was statistically significant. And I don't know why the intervention would work better in Botswana than in these other two studies, because the incidence of AIDS is similar within these three studies. So I didn't quite understand it, but at least this study gave a positive result, although they couldn't convince the poor men to get circumcised very often. That was that. The next topic in the New England Journal concerns blood pressure. And why is blood pressure important? This little illustration is from Science, 2018. And these are the 10 top contributors to deaths worldwide. And the most common cause of death worldwide is cardiovascular disease. And high systolic blood pressure is by far number one. Then comes smoking, sugar, solid fat, liquid fat, and after that come all the things that the Germans are worried about, diesel cars and this sort of thing. So if you look at this little picture here, if we all start driving electric cars tomorrow and institute a massive tax on CO2 production, I think those ideas are okay, but it will not alter this result one iota, because the things that really count are these first 5 items with systolic blood pressure way on top. Now, in the United States, the recommendation has been made, and also in Europe, that blood pressures above 130 over 90 millimeters of mercury should be, or above 130 over 80 millimeters of mercury should be treated. The recommendation used to be 140 over 90, and it's now moved to 130 over 80. And so in the study that I'm going to show you, a huge epidemiological investigation was done in the United States to see if these recommendations are worthwhile. And one of the statistics that's used here is the Z-score. And the Z-score is basically a standard deviation from the mean value. So if we have a normal distribution, then one standard deviation would be a Z-score of 1. 2 standard deviations would be a Z-score of 2, etc. So, and if the distributions are not Gaussian, then adjustments are made for calculating these Z-scores. So that's what that means. So this study concerns the Kaiser Permanente healthcare system, which comprises actually Northern California, Oregon, Washington, and this healthcare system was founded in World War II by the Kaiser company that produced aluminum, or aluminium if you're Boris Johnson. And the industrialists were interested in their employees, that the employees should receive a reasonable health care. So the Kaiser Permanente system, which has nothing to do with Kaiser aluminum anymore, is a massive healthcare system that involves a whole chain of hospitals and outpatient facilities monitored with an excellent electronic medical record system, so that the physicians know what happens to these patients. And so we're talking about 1.3 million people that were monitored over a period of 8 years, that have their blood pressure measured by an automated device, as was done in the SPRINT study. So we look at this massive cohort. We're interested in, these are adults, obviously. They're middle-aged, 50. Half of them are women, or a little more than half of them are women. Various ethnic groups are involved here. And the incidence of diabetes and history of stroke or hyperlipidemia are pretty much what we would expect in the general population. Now then, they divided the patients in terms of their blood pressure values. Those greater than 130 over 80, which we would consider to be the cutoff for subscribing a medication today, and those 140 over 90, which results in a different distribution. Now, it's not surprising that systolic and diastolic blood pressure are vaguely correlated with one another, and that was the result here. Now, if we classify anyone that has a blood pressure greater than 130 over 80 as being hypertensive, that is a lot of people. And if we, then only 60% of the people would get the predicate of being normal. And if we classify hypertension as being greater than 140 over 90, then this number is substantially reduced, and the number of normal people is 80% compared to 56%. No surprise there. Now, if we look at systolic blood pressure, if we greater than 140, blood pressure increases with age, as we might expect. So at my age, 25% of the people would be classified as hypertensive. If we pick the value of greater than 130, then it's half the people would be classified as hypertensive. And diastolic blood pressure is a little different. It rises until about age 40 to 50, and then with increasing age, diastolic blood pressure actually decreases so that the pulse pressure increases with increasing age. And if we use this threshold, then here are the diastolic blood pressures in terms of percentage of all the measurements, but again, we see this decrease after age 50 with an increase in pulse pressure. So if we look at unadjusted analysis of systolic blood pressure and your chances of having a bad outcome, there's an increase with systolic blood pressure as we would expect, and this increase becomes much sharper when the quartiles of blood pressure are at the higher levels. And for diastolic blood pressure, we see this more U-formed or J-shaped relationship. But if we adjust this relationship for a whole bunch of other variables, age, body mass index, other risk factors, then this U-shaped relationship disappears, and we again see a relationship that's based on the degree of blood pressure elevation. And if we express this as z-scores, indeed, systolic blood pressure seems to have a greater effect than diastolic blood pressure, but this positive relationship for diastolic blood pressure is still maintained. So in conclusion, it looks like this J curve can be explained when we adjust the data for all the risk variables. And the investigators conclude that since if we use the definition greater than 130/80, this risk increases with increasing levels of blood pressure, that this definition of hypertension in terms of requiring treatment with medications is justified. Now, the review in the New England Journal concerns drug-induced liver injury, which is fairly common, and we can divide that into three particular issues. Some agents are directly hepatotoxic. That's modified by a number of variables that I'm going to show you. Then there are agents that cause an idiosyncratic hepatotoxicity. That's not as common. That's actually fairly uncommon, but it needs to be recognized. Then there are agents that cause an indirect liver injury in that they result in an environment so that underlying liver diseases such as hepatitis B virus, C virus, or fatty liver disease have a more destructive effect on the liver than they otherwise would. And this is discussed in substantial detail in this actually excellent review. And the first issue involves direct hepatotoxicity that may involve drug metabolizing enzymes, regulation of hepatoprotective pathways or down-regulation of hypersensitivity reactions, etc. An example would be toxicity from amiodarone. And here's an example given here. In this patient, amiodarone was given parenterally at a high dose. When direct toxicity is suspected, the drug should obviously be stopped. It's possible to reintroduce these agents, and when this patient then received oral amiodarone, this direct hepatotoxicity did not occur. Panel B shows an example of an idiosyncratic reaction. This patient received a single dose of cefazolin, and I think the bottom line here is that hepatotoxicity from antibiotics is pretty common. Panel D shows an example of bland cholestasis. This patient took an oral anabolic steroid, probably a bodybuilder or something of this nature, that resulted in that reaction. So these conditions and the drugs that cause them are discussed here in substantial details. And here's a table, the most frequent causes of idiosyncratic reactions from prescribed drugs. And of these 13 agents here, antibiotics consists of top 9 of the top 10 causes. So a word to the wise should be sufficient. Also, herbal and dietary supplements are implicated. The pathogenesis of these adverse reactions is related to HLA class, which I didn't know, and we have to recognize these things so that we can deal with them. This little report in the New England Journal concerns a 41-year-old woman who wears contact lenses and doesn't take them off when she goes swimming in the lake. And this keratitis is caused by an amoeba, Acanthamoeba polyphagia. And here's another example. What are acanthamoebas? These amoebae have these spikes on their external membrane, and that's why they're called acanthamoebas. These are fairly common, and they're found in fresh water, and they can affect the eye, and they can also affect the brain if you happen to suck up water through your nose, and we have to recognize the conditions of this. This patient from last week is the 7-year-old boy that has these lumps on his tongue. These are neurofibromas, and this patient has a mutation in the RET proto-oncogene. So this is multiple endocrine neoplasia type 2B. The danger here is the development of medullary thyroid carcinoma, but we can screen for that by measuring calcitonin. That was done in this patient, and his thyroid gland was operated upon accordingly. And these patients also have a propensity to develop pheochromocytoma. The patient of the week, the case of the week in the New England Journal involves this 65-year-old person who underwent a sex change operation 30 years earlier. That state of affairs has nothing to do, in my view, in terms of what happens to him during this case, to her during this case presentation. As you can see from the images here, this patient has a stroke, and transthoracic echocardiography shows that the ejection fraction is only 32%. And so a cardiac magnetic resonance imaging study was done, which was consistent with myocarditis. I wasn't shown an electrocardiogram, so I'm not certain, but the patient may have very well also had atrial fibrillation, so this looks like an embolic stroke. Then we learn that the patient underwent coronary angiography and had normal coronary arteries. The patient received a resynchronization device as a treatment for heart failure, and the patient is treated with a whole host of medications: aspirin, apixaban, atorvastatin, furosemide, hydralazine, isosorbide dinitrate, metoprolol, spironolactone, omeprazole, and eye drops, all sorts of things, about 12 items. Now, try to take 1 tablet a day and remember to take it, and then try to take 12 things. I have no idea why this patient got atorvastatin if he had normal coronary arteries, and an explanation for the heart failure, which was myocarditis. But then what happens is the patient develops dark urine. And if we look at this dark urine, amber-colored urine, a dipstick test for blood is 3+ positive, but inspection of the urine under the microscope showed no red cells. So this is not hemoglobinuria. This has to be myoglobinuria. And if we look at this muscle enzyme here, creatine kinase, which should be less than 150 units per liter, this patient has a creatine kinase level of 20,000. And then the mystery is, why does this patient have an acute myopathy? This is probably not a genetic disease if it shows up at age 65 suddenly. And we know that HMG-CoA reductase inhibitors can cause muscle disease, acute muscle disease. So that's number 1 on our list. So the discussant here discusses rhabdomyolysis, which this patient clearly has. Not very common in statin users. Thank goodness, only 2 to 5 in every 100,000 statin users, so this is not common. But what we learn about is that in statin-associated autoimmune myopathy, and that's what this patient has, if we stop the statin, the disease doesn't go away. Now, there's a direct toxicity of statins on muscle, whereas if you stop the statin, the condition almost invariably gets better. But some patients develop an antibody against HMG-CoA reductase. And exactly why the administration of statin results in this basically autoimmune disease, I don't know. But this condition, which also results in myopathy, doesn't go away when you stop the drug. So a biopsy is done here, and then this patient's autoantibody titer against HMG-CoA reductase was measured, and it was markedly elevated. And some stainings were done, which shows the presence of this antibody attacking these muscle cells. So if this is an autoimmune disease, immunosuppression, prednisone, rituximab, these kinds of things, and that's how this patient was treated. What's also discussed, and I think this is worthwhile reading, is how to deal with patients that have undergone transgender procedures, or how to gain their confidence so that they can be treated like any other patient would be treated. And the discussant here even has a table on principles of gender-affirming care, and this is for physicians, this information is certainly very worthwhile knowing. So what we learned about from this case report is a very rare, 2 in a million might develop this problem. Antibodies against HMG-CoA reductase as a cause of statin-induced myopathy. Now in the Lancet, the first issue has to do with cerebral blood flow. And this review by Julian Payton, who I happen to know, I thought was very interesting, because it turns out that we can direct cerebral blood flow by dealing with autonomic mechanisms that control cerebral blood flow, and we have access to these things because we can stimulate or anesthetize, or whatever the strategy is, certain ganglia that are accessible to treatment. And one of these ganglia is the sphenopalatine ganglion, and we can increase cerebral blood flow by stimulating the sphenopalatine ganglion, so that collateral blood flow in patients that have had a stroke could possibly be improved. And the review concerns that issue. And the ganglion that we're going to look at is the sphenopalatine ganglion. So the next time you're picking your nose, if you reach for the upper turbinate, you're going to be close to the sphenopalatine ganglion. Here it is, and it controls a whole host of things, but it also has an influence on cerebral blood flow, which is shown here. So there it is. It's above the third turbinate. And we can get at it with a bent Q-tip probe like that, or we can even implant a small device through the nose to stimulate this ganglion, and this is a treatment that's used for cluster headaches that we discussed last week. But in these particular trials, here's a paper out of stroke. Now, the journal's called Stroke, but the patients all had stroke, and they didn't meet entry criteria for thrombolysis therapy. So these patients were randomized to treatment, stimulation of the sphenopalatine ganglion or not. This was a large intervention trial, multi-center intervention trials. And if we look at the Rankin scores, we'd like to, in the intervention group, we'd like to push all this stuff over to the right. Now, the differences here are not statistically significant, but they're sort of promising, I thought. Whether or not the data are analyzed modified intention to treat or confirmed cortical involvement that's shown by imaging studies. This study was stopped prematurely because better devices are being developed to apply this treatment. So in this paper in the Lancet, This is a large study of stimulation of the sphenopalatine ganglion in patients that have had a stroke that are not candidates for thrombolysis therapy. And here's the device. It's about the size of your fingertip, and it can be applied with this applicator through the nose, and it sits there against this ganglion, and presumably when you don't need the device anymore, it can be extracted and removed. So this is the stimulating device. And so the analysis here is modified intention to treat or documented cortical injury, or however you want to do it. Fairly large numbers of patients, 400 overall patients, 1,000 were evaluated according to this criteria and 520 according to that criteria. A lot of these patients are hypertensive, which we would expect, and atrial fibrillation is common, and a lot of them are still smoking, but all of these variables were similar in these groups. And these are the Rankin scores that we'd like to push to the right. We'd like to have more people with scores of 0, 1, or at worst 2. These are patients that can still then care for themselves. Well, this analysis was also not statistically significant, but it nevertheless looks promising. 14% here, 8% there, 17% here, 13% there. The more patients that we have patients that can take care of themselves, the better off for this devastating. So it looks favorable. So didn't quite cut mustard, but it looks pretty good. And the degree of stimulation, low to mid-level stimulation for stimulating this device, seemed to be adequate. And so this looks like a promising avenue of giving people that have had a stroke a somewhat better outcome. And I thought that this was clever. Then what do we do with old people my age that have an acute coronary syndrome, who might already be taking warfarin, or maybe have already had a cerebral hemorrhage, and we're not real crazy about giving them clopidogrel and aspirin and all of these various things, because they might have a complication, a bleeding complication. So an old-fashioned treatment was used in this study. Drug-coated balloons were compared to bare metal stents, and these old people that had an acute coronary syndrome or an acute myocardial infarction. So here they are, 77, I know that. Mostly men, but women are also here. Some of them are still smoking, but all of these things were the same in both groups. So one group got a bare metal stent, the other group were treated with the old-fashioned balloon treatment, but the balloon was coated with a Taxol, paclitaxel. And so if we look at the vessel involvement here, the distribution in both groups is about the same. The maximum dilatation pressure is somewhat different because the techniques are different. As you're probably aware, the number of atmospheres that have to be applied here. But what we see here is that major adverse cardiac events were a lot better in the balloon group compared to the bare metal stent group, which I thought was interesting, irrespective of what kind of lesion it was. And the balloon group did quite a bit better. So here, the blue guys are the balloon, or the balloon guys are the blue guys here, and the bare metal stents are the red guys. And the bare metal stent patients, a couple of the stents thrombosed and closed, whereas this was not a problem in the balloon group. So maybe treating old patients with acute coronary syndromes, maybe they're better with a balloon, seem to indicate that. I think Bill and Melinda Gates have made a major contribution to healthcare worldwide. And this is another one of these New England Journal Lancet papers that is so politically correct, I think it's just amazing. So this is a study involving the prevalence of mental disorders in conflict settings. Conflict settings is a politically correct term now for war zones. And you might imagine that in war zones, depression and mental illness would be more common than in more Pacific places. And that was tested here. So the conflict settings are shown here. We can look at You can pick your favorite places here, the Balkans or Syria or various places outlined here, East Timor and Pakistan, etc. The border between China and India and these various places. And the size of the circles looks at the anti-anxiety data points or the depression data points. And I think the paper is depressing. I think it's sort of a no-brainer that mental disturbances would be more common in war zones than in peace zones. And that's what this study shows. So depression and conflict, red. Anxiety and conflict, also red. Post-traumatic stress disorder, also more common. And we can look at the details here. So, no surprises here. The reviews in the Lancet concern oral health, and this is important because the quality of your teeth and gingiva is a very good indicator of your general overall health and what the outcomes might be. And oral health is largely a function of what people are given to eat, and that's the point here. So oral health. Key messages, integral element of overall health, we know that. Do poor people have worse oral health than rich people? Probably. And of particular concern is the effect of free sugar consumption on the prevalence of caries, overweight, and obesity. Now, it won't surprise you to learn that people with a managerial job do better in terms of the number of teeth that they have compared to manual laborers, and that in the rich countries, this is better than in the poor countries, and the homeless are, they're in bad shape irrespective of where they are, and no surprises there. So the burden of oral diseases is an international problem. And I suppose it shouldn't surprise us, but the global sugar industry that has accumulated revenues more larger than the gross national product of most of the countries that we're talking about here is responsible for a large part of this problem. And Coca-Cola and PepsiCo and the American Beverage Association, and the Europeans are not innocent here either, bears a brunt of responsibility. And the second review is what could possibly be done about it. And the messages here are the same as I've outlined. And you can look at the fine print on your own, but prevention is certainly possible. In the United States, the fluoridation of drinking water was introduced in the 60s, and the number of caries diminished substantially until, at least in Indiana, someone came up with the idea that maybe fluoridation of drinking water was a communistic plot, and they abandoned it. But they kept the fluoride in toothpaste. Well, you have to have money to buy toothpaste, but everybody is subjected to drinking water. And what the European politics is on the fluoridation of drinking water at the moment, I don't know. But that's an important avenue. And also, baby foods, since women aren't that interested in breastfeeding anymore, and baby foods are laden with sugar. And the annual growth rate of commercial baby foods, China, United Arab Emirates, Vietnam, Indonesia, Russia, the Czech Republic, this is where the sugar comes from, and it's introduced at an early age. So these are important reviews. Then I was interested in this little bit of molecular biology in the New England Journal because we're dealing with medications now that are based on RNA treatments or even CRISPR-Cas9 treatments. And we've looked at papers that use these as medications, as drugs. And with CRISPR-Cas9, we can use a guide sequence and attach that to the enzyme Cas9 that's shown here in green, which is then able to snip, cut DNA at a desirable place. And the question is, how do we shut this off? And how to avoid off-target, where cutting occurs at places that we don't want. And this is a major problem. And so we have to introduce medications to stop the medicine, in essence, what this involves here. And strategies are being developed to deal with this issue. And the first one, how to shut off CRISPR-Cas9. RNA oligonucleotide inhibitors have been developed that bind to the guide sequence of the guide RNA so that this complex is then degraded and so that the effect of the agent is stopped. And also in terms of shutting off short interfering RNAs and shutting off antisense oligonucleotide. Strategies are being developed to stop these agents so that off-target binding doesn't occur. And I think the little review in the New England Journal draws your attention to that and the mechanisms that are being developed to deal with that issue. And then in JMA, what are the guidelines now for acute ischemic stroke? Well, we've discussed this before, and the patients that have an ischemic stroke within 3 hours, within 4 hours, perhaps 9 hours, although that isn't mentioned in these guidelines, should receive hemolysis therapy. If you have people that can conduct mechanical thrombectomy, and if the internal carotid artery or proximal middle cerebral artery are involved, there's good evidence that this treatment helps. Mechanical thrombectomy with a stent retriever is also recommended for certain acute ischemic strokes, and the guidelines are given. We'll stop with this case report. And this poor patient was in the Lancet. This is a 28-year-old Egyptian woman who has 2 young children. She develops irregular vaginal bleeding and consults a gynecologist. He determines that her hemoglobin is 10. So she receives treatment with diosmine tablets. Never heard of those, so I had to look those up. And basically, these are dandelion leaves. And she's also given a prescription for birth control pills and is sent away. 6 months later, she returns with the same complaints and hasn't gotten any better. And a transvaginal ultrasound is done, and it shows this fairly substantial uterine mass with fairly reasonable perfusion, but heterogeneous perfusion, and this mass is biopsied and a diagnosis is made. What interested me is neither of these examiners performed a bimanual uterine examination. I would think that with this problem, this condition could have been palpated by hand. Ultrasound is probably better, and perhaps bimanual examinations are not even taught anymore, because either care facility reported the results of a bimanual exam. But at any rate, this lesion is biopsied, and it turns out to be a hydidiform mole. Don't need to do a CT to make this diagnosis, but you can see this large intrauterine mass. And these tumors are fairly aggressive, and I was interested to learn how they come about, because this is abnormal trophoblastic tissue, and this tissue has lost the female genome set and instead has a double male genome set, which is clearly abnormal, and the propensity to malignancy is high. That's it for this week. Next week. And if you're interested, you can hear the same business in German in 10 minutes.